This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 16, Behavioral Emergencies. An introduction. Many emergency care professionals feel uncomfortable and unprepared when treating patients in behavioral emergencies. Uncertainty stems from the lack of behavioral emergency protocols and knowledge that behavioral emergency are not as predictable as other calls. There are no classic presenting signs or symptoms for individuals with behavioral disorders. The problem for the responders is that abnormal behavior may stem from mental illness or some other condition, medical in nature. Drug or alcohol abuse, cerebrovascular accident, infection, and metabolic disorders each can cause symptoms that appear to indicate a behavioral or mental problem. So when treating behavioral patients, psychological emergencies require a calm, professional approach. Seek privacy for the interview, but do not sacrifice your safety. Let the patient tell his or her own story. Provide non-judgmental reassurance. Develop a clear plan of action. Never leave the patient alone. Never assume talk is impossible until you've tried it. There are several emotional disorders that we may end up treating. Anxiety disorders. The patient may just be anxious and have nothing more than hyperventilation syndrome. Depression and bipolar disease. They may be manic. They may be super depressed. Personality disorders like schizophrenia or delusional disorders. EMS rarely uses pharmacological intervention. However, if you need to use pharmacy intervention, please do so. Safety of the patient, safety of the provider, and that's you, should be taken into consideration when making a decision on this. Supportive measures are generally how we treat these. Secure surroundings to where the patient feels secure. And I'm not talking about we throw up walls and get a SWAT team in there. I'm talking about very simply that you make the patient feel secure in the surroundings. So you have to really work on the development of the rapport. Behavioral drugs that we're going to talk about in this section: Chlorpromazine or Thorazine, Diazepam, Droperidol, Fluphenazine, Haloperidol, and Hydroxyzine. Chlorpromazine, this is a general knowledge drug, so this would be essentially the names and mechanism of action. Generic Chlorpromazine, trade name on this is going to be Thorazine. You ever heard of the Thorazine shuffle? It's classified as an antipsychotic. Mechanism of action: phenothiazine antagonizes dopamine 2 receptors in the brain. Depresses release of hypothalamic and hypophyseal hormones. May also depress reticular activating system. Adult dose: psychosis for alcohol withdrawal, 25 to 50 milligrams. Initially may be repeated in 1 hour. Pediatric dose on this for psychoses is 0.55 milligrams per kilogram IM. Contraindications: any hypersensitivity to chlorpromazine or thorazine or phenothiazines or sulfites. Do not use in patients with narrow angle glaucoma. Severe cardiac disease, CNS depression, patient who have taken any hallucinogens. Pharmacokinetic half-life 30 hours and is excreted in the urine. Diazepam, this is a primary care drug. Generic on this is Diazepam, and the trade name is Valium. Mechanism of action, I'll make this simpler rather than reading that. It is a GABA agonist. It's a benzodiazepine and GABA agonist. We use it for CNS depression. This will cause a calming effect. It decreases the amount of action potential that you have in the cell. So let's say that this was a brain cell, and on the surface here you had a GABA, and it is a chloride port. Well, chloride is a negative charge. If you're trying to generate an action potential in the cell or have energy in there to create a synapse, the more negative electrons that are coming into the cell, the decrease in threshold that you have. So what this medicine actually does is it decreases intracellular action potential generation. Adult dose on this, seizure, status epilepticus, or just a calming effect. We can go up to like 10 milligrams on this drug. Total on this, by the book, is 30 milligrams. I want to give you fair warning. If you get above 10 milligrams on this, you have, even with 10 milligrams, this can depress their CNS levels enough to where it could cause respiratory arrest. Pediatric dose, greater than 5 years, 1 milligram slow IV push. Less than 5 years, 0.2 milligrams to 0.5 milligrams, and slowly ease them into a therapeutic index. Onsets 1 to 5 minutes, give the drug time to work. Duration 15 to 60 minutes, and is excreted in the urine. Contraindications, hypersensitivity to diazepam, benzodiazepine, propylene glycol, pre-existing CNS depression, so if they're already comatose, they don't need it anymore, or acute angle glaucoma. Droperidol, general knowledge. Generic is Droperidol, and the trade name is Anapsin. Mechanism of action, anti-emesis, dopamine receptor blocking in the brain, predominantly dopamine 2 receptor, and when reuptake is prevented, a strong anti-dopaminergic, anti-serotonin response occurs. Now, Droperidol is a dopamine antagonist, essentially, so it's going to have the same effects as, say, Haloperidol. Dopamine is one of our neurotransmitters in our brain, and what this medicine does is it blocks that, so it causes a CNS depression. Adult dose 2.5 milligrams IM. Pediatric dose not recommended for out-of-hospital care. Contraindications, hypersensitivity to droperidol or phenothiazines. Do not administer to patients with narrow-angle glaucoma, CNS depression, severe cardiac disease, or patients who have taken any kind of hallucinogens. Pharmacokinetics, onset in 3 to 10 minutes, duration 2 to 4 hours, and excreted in the urine and feces. This medicine has tons of medication. If it's mixed with another medication, has tons of untoward effects. So got to be careful with what they're on if you're actually using droperidol or Anapsin. Fluphenazine, trade name on this is Prolixin. Mechanism of action, phenothiazine antagonizes dopamine 1 and dopamine 2. Are we seeing a pattern here? This is a dopamine antagonist as well. Depresses release of hypothalamic and hypophyseal hormones. Adult dose on this is 12.5 to 25 milligrams IM. Pediatric dose not recommended for pre-hospital use. Contraindications, known hypersensitivity, CNS depression, and concurrent use of medications that prolong QT intervals. So this is probably going to prolong our our QT interval. So this can cause arrhythmias very easily. Pharmacokinetics, onset 1 hour, duration 6 to 8 hours, and is excreted in the urine and feces. This is a primary care drug, Haloperidol or Halidol. Mechanism of action, phenylbutyrpyridine antagonizes dopamine 1 and dopamine 2, so this is a dopamine blocker. Inhibits the release of hypothalamic and hypophyseal hormones. Adult dose 2 to 5 milligrams IM or 0.5 to 5 milligrams IM. Pediatric dose not recommended for pediatrics in out-of-hospital setting. Contraindications, hypersensitivity to haloperidol or phenothiazines. Do not administer in patients with CNS depression, severe cardiac disease, or narrow-angle glaucoma. Pharmacokinetics, onsets in about 30 to 60 minutes. Duration is about 10 to 20 hours. Excreted in the urine and feces. Hydroxyzine, general knowledge. Generic is hydroxyzine. Trade name is Atarax or Vistaril. Mechanism of action, it has antiemetic, anticholinergic, and antihistamine effects. Acts as a CNS depressant. Now, this medication coupled with some of the psych meds tends to potentiate the psych meds, so they mix these quite often. Pediatric dose, or adult dose, 25 to 100 milligrams IM every 6 hours, and pediatric dose is 0.5 to 1 milligram per kilogram dose IM every 6 hours as needed. Contraindication, hypersensitivity to hydroxyzine in pregnancy, and there's a potential, if we use it, for congenital defects of the fetus. Pharmacokinetics: onset 15 to 30 minutes and duration is 4 to 6 hours. This is eliminated in the urine. Conclusion: patients who present with irrational behavior may do so because of disease or injury, not because of mental illness. Examples of this would be things like electrolyte disorders, encephalitis. We'll talk about this more in medical emergencies. If possible, the patient who presents with a psychotic behavior should be assessed for other medical and physical causes. If the patient's problem is in fact psychiatric in origin, treat the patient appropriately. It is more appropriate to give antipsychotic drugs in the hospital setting, which is a more controlled environment. There may be occasions when out-of-hospital antipsychotic drug therapy is ordered before transport to an emergency facility is complete. As with any emergency situation, follow your local protocols. References from this was taken from Beck's Pharmacology for EMS providers, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.